Hi, my name is Kariem El Boghdadly. I'm an anaesthetist in London with a special interest in regional anaesthesia and acute pain management. It's a pleasure to be joining you for World Regional Anaesthesia Day and to answer some questions that have been posed to me. So why have we not been successful in perioperative pain management, or where can we go to from where we are now? I think the question of have we been ineffective is a difficult one because we have been effective in some patients and been ineffective in others. And I think this is where we have scope for growth and development. We've been putting all patients into one giant pot and imagining that they all look the same and the same intervention should work for all of them. But every patient is different. We have different patient characteristics, different patient expectations, different types of procedures, different previous experiences that patients may have. So what we next need to do, and what we really need to think about as clinicians, is each individual patient. Some patients really don't need a regional anesthetic intervention, or really only need minimal analgesic intervention, systemic analgesia. Whereas others, even with the same type of procedure, low risk surgery, may require more intervention and escalated intervention. So I think where we have failed is to strategize and to titrate and to really articulate the pain management required for each individual patient. Rather than assuming everyone is the same, what we need to do now is to say, right, this patient has these characteristics, therefore they're more likely to have moderate to severe acute postoperative pain. Therefore, I'm going to have to escalate my analgesic management. So more patient-centered care. So what are the fundamental principles of perioperative pain management? Well, I think what's important is to think about the perioperative pathway as a whole, rather than the immediate preoperative, intraoperative, and postoperative period. So this has to include a consideration of pre-admission and what we do on admission, as well as obviously intraoperative in hospital, but also how we prepare for discharge and what we do with patients, how we work with them following discharge. So it's important to think about the entire pain management perioperative pathway. And what the key principles of this are that we should be assessing pain based on function rather than based on a numerical pain scale alone. Being a little bit more comprehensive in thinking about pain management rather than a single isolated number. We've got to be using multimodal analgesia throughout the perioperative pain pathway, and we really need to think about non-pharmacological strategies for perioperative pain management, which is something that we maybe haven't really been leaning on as much as we could have done. If opioids are used, we've got to ensure that we've planned for the use of opioids, either by careful opioid stewardship and titration up and down, as well as planning and safety netting for opioids and their undesirable side effects. So that will include, whenever we use opioids, ensure that we prescribe medications for the potential adverse events, and also be very careful and cautious with our opioid stewardship. And finally, we need to maximize the use of regional anesthesia where appropriate, with protocols, support, and training for staff in the perioperative management. So thinking about the entire pathway, and these are some of the key fundamental tenets of effective, safe perioperative pain management. So the perioperative pain management based on a patient's function rather than isolated static or rest pain scores. This is really important because what we're trying to do is we're trying to get patients to get back to their baseline as quickly as possible. And the baseline really should be what they're able to do functionally beforehand. So what we need to be targeting is ensuring that patients have analgesia that allows them to be able to do the functional expectations that they had preoperatively, which is what everyone will have postoperatively. Pain alone should not be the end target. It's pain management for both humanitarian reasons and patient comfort and patient experience, but fundamentally, the patients need to be able to get up and go to work, go home, look after their family, do their cooking, do their shopping, and that all comes down to basing pain management on function, not just pain scores alone. My key message is really thinking about each individual patient and thinking about the entire perioperative pain pathway. So if we think about each individual patient, we're actually going to be considering that patient's characteristics and the type of surgery that they're having, and titrating whether we do need escalated interventions or not. It's going to be thinking about that individual patient and understanding whether they've been on opioids before, and do we need opioid tapering, and what sort of opioid safety netting and education do we need. It's thinking about each individual patient and assessing and considering what their post-operative functional requirements are likely to be. So if we consider the patient as a unique individual, then we can titrate pain management, perioperative pain management throughout the entire pathway to the best of our abilities for each individual patient, rather than trying to shoehorn all patients into the same mold. So thinking about each individual patient and considering the entire pain pathway.